Thank you very much, Joelle, for that comprehensive and really generous introduction. It is ICHOM, but definitely forgiven if you pronounce it otherwise. And it really is a pleasure to be back here to talk more about what is really near and dear to my heart. And what is at the core of what we do every day at ICHOM, which is thinking about and taking action with regards to which outcomes matter for patients. So, my background, you've heard a little bit about, and my calling towards this work, which I'd characterize as driving health system transformation in a way that serves all patients, really started at an early age. It was specifically at the age of 14 when I lost my mother, who's pictured here. She's my biological aunt, but took care of me from a very young age. She died of breast cancer. She died, this was in Botswana, so she died of late diagnosis and lack of treatment at a time when the country had only one oncologist. But she also died of not having had good quality of life and good quality of death. And so this experience for me, it was really painful as an adolescent girl who's losing her mother. But it was actually really eye-opening in a way that only looking back you can characterize well, because it made me pursue a career in medicine. I went to the US to study medicine, and to study not just clinical medicine, but to think about population health and health systems and equity and ways in which systems can really speak to what people are seeking when they go to healthcare services. And so that's been my experience. I've worked in many different countries and contexts, including the US and the UK, Haiti, multiple sub-Saharan African countries has been mentioned. And I say this to be able to give you some perspective from which I'll be coming to this conversation. So it is as a member of ICHOM who we see ourselves as a pioneer in this value-based care field, and also in being able to drive patient voice in the way that health systems are reimbursed and incentivized. But it's also as a physician, as many of you are in the room, as a public health specialist and global citizen, and I think importantly as a mother. I'm a mother of two young kids at risk for breast cancer, and somebody who might one day experience the care for breast cancer or other condition in the UK health system, of all places. So I hoped over the next 20 minutes or so to be able to share with you some thoughts from these perspectives, one being which outcomes really matter and how we have framed it based on ICHOM's experience over the last 10 years and expertise working with international experts. And also to think about knowing and having the motivation of which outcomes. How do you do it? It's already been said, it's really challenging the how. How do you capture outcomes that matter most to patients in a way that is feasible, doesn't interrupt and add to the fatigue of reporting and indicators that seem to be everywhere, but also you can gain value, whether you are a patient, a clinician, canton administrator, and even drive innovations in research in other spheres. So I'm going to breeze through this slide. I think everybody in the room is, I hope everyone in the room is familiar with value-based healthcare. And of course, the idea of patient outcomes is derived from the value-based healthcare framework that was described by Elizabeth Teisberg and Michael Porter. It is the numerator of the value equation, where really we're looking to have health systems aim to achieve better outcomes that matter to patients at better cost. And value-based healthcare, that book was published many years ago, and value-based healthcare has more recently really gained impetus in terms of innovation and implementing the value-based care programs. This is an example of some of the value-based care programs and initiatives in different countries, as well as regionally and internationally. I'll point out the Lancet Commission on High Quality Health Systems, led by Margaret Crook at Harvard, which was also mentioned, I think, in an earlier session, as well as OECD's initiative to look at outcomes and data generated from patients to add to the understanding of how health care is helping patients and people. So I think one of the drivers of the impetus for value-based healthcare, there are many, and some of them have been highlighted by Stefan, like the value crisis, evidence crisis, and the crisis of purpose that clinicians feel in delivering care today. One of the drivers of this impetus is the disconnect that's evident between what health systems are currently measuring and what matters to patients. So if you look at what indicators are typically collected and reported and reimbursed for, they are overwhelmingly, they do include outcomes like survival and biomarkers, but they are overwhelmingly processes of care. So for example, diabetes, which we've touched on earlier, the hemoglobin A1C and glycemic control is an outcome, it's a biomarker. But associated with this, a lot of indicators have whether the test was performed, whether a visit occurred, and for conditions where surgeries and procedures are prominent, is whether the procedure or the MRI and CT scan was done. So all of these are processes. They are processes of care, but not the result of care. If you ask patients what they are looking to get out of seeking medical care, it might look something like this, and it really boils down to getting back to a normal, joyful life. So they do care about living and surviving, right? But they also care about being pain-free, caring for themselves independently, going back to work as soon as possible, which has implications on economic productivity. As well as there's an example for a patient perhaps who has arthritis and has received hip replacement, is being able to kick the ball and dance with grandkids, right? So patients are expressing survival and over and above survival, well-being and functioning at the physical, mental, and social dimensions of living. And patient-reported outcomes in particular try to bridge this gap of capturing well-being and functioning that doesn't exist, at least not prominently, in the way that healthcare is assessed and reimbursed today. Now, with patient-reported outcomes, there's also the issue of how do you measure them, and there's a challenge there. In the context of value-based healthcare and general research in health, there's been a proliferation of instruments or questionnaires that measure patient-reported outcomes. This is a table that was of a paper that was published by colleagues at Erasmus, which describes the different PROMs that exist for breast cancer. Some of them are disease-specific for breast cancer specifically. Some of them are generic, meaning they can be used for different types of cancers. If you look at them, some of them have 30 questionnaires, some of them have as few as 6. They are measuring different types of outcome concepts, and they have different total scores. And also even the questions that they ask patients are either, have you had this symptom over the last 7 days, or has it been over the last 4 weeks, or today, right? So there's a difference in the recall period of the instruments. When you look at the scores and how to interpret the scores, there's difference in directionality. Some instruments, a high score means a good health status, whereas some instruments, it means a poor health status. So you can imagine that having this alphabet soup of acronyms and instruments can be very daunting for somebody who is not a researcher and heavily steeped in this space. So there's a need to be able to curate and make more digestible the measurement of outcomes for patients. That is simplifying, making them more pragmatic, and standardizing to some extent. So I will touch on which outcomes and how we arrive at those outcomes, and as well as how to measure and gain value from measuring from the experience of ICHOM. So really ICHOM, as is mentioned, is an international nonprofit that is born out of a need to address some of these challenges, to be able to standardize the way to provide global standards for measuring outcomes that matter to patients in a way that can drive and unlock value-based care and can be used by different stakeholders to act towards this transformation. We very much focus on the numerator of the value equation, and we were founded in 2012 by the pioneers of value-based healthcare, including Michael Porter, Stefan Larsen, who some of you heard from today, and Martin Ingvar. So what are our ICHOM sets of patient-reported outcomes, of patient-centered outcomes? This is a wheel for diabetes, but we have this for each of the disease areas that we have sets for. It covers the outcomes that are important to patients. And I'm for those of you who have heard this before, I apologize, but I want to emphasize a point. The outcomes that are captured in ICHOM sets are patient-reported outcomes, such as depression, distress related to a condition, sexual functioning, for example, for prostate cancer. But they also include clinician-reported outcomes. So it doesn't mean implementing the set doesn't mean you move away from the clinical endpoints that you're used to using or reporting in registries. It just means augmenting and providing a more holistic perspective of how the patient is doing based on the patient's perspective. These can be used for in various ways. I'll just provide some examples. So as they can be used for being able to enhance the conversation between patient and doctor, not in a way that, again, ignores the guidelines or ignores the evidence in terms of which medicines work, but thinking about if I'm a patient with a particular BMI and age and some risk factors, what are my reasonable expected outcomes and goals of care? If I have terminal cancer, what are my goals of care that are important to what is valuable in my quality, in my way of living? So I think all too often it feels like this shared decision making feels like maybe the patient is perspective is overriding the clinicians, but it really is a shared conversation, keeping in mind the preferences and what quality of life looks like for the patient. The other is improving quality of care within and processes within the practice. So we've talked about this a little bit. There are opportunities to be able to have patients who are stable, who can be managed at home without having to come to clinic every week or every month. So in that way, it's more convenient for patients. It also saves time for clinicians and the practice. On the flip side, it's also patients who are at high risk, being able to pick up when a patient has a red flag symptom in a way that can be communicated and picked up from the scores, the patient-reported outcome scores. So there are ways in which measuring patient outcomes can really help with addressing the pain points that clinicians, that healthcare providers, as well as patients face. And then I'll just point out one about disparities and equity. So our sets include, in addition to the outcomes, they include case mix variables. So these are socio-demographic factors like education and race, ethnicity, as well as comorbidities and other factors that can be used in analysis to look at your groups of segments of patients to see if any are experiencing worse outcomes than others, and trying to figure out why that might be the case and improve and innovate the services available to be able to serve them better. In the longer term, an analysis like that might be used to have payment of care, recognize the importance of providing social care, providing extra talking time and counseling for patients in a way that really does help patients and in a way that clinicians are paid for their work that improves these outcomes. So in addition to the outcomes, I've mentioned that our sets have case mix factors. The sets also standardize, provide some details that really help standardize the data that's collected. Now, this is important if you're going to be wanting to make meaningful, credible conclusions about the data, either over time, say one patient or a group of patients over time, or over space, if you want to compare patient groups from hospital A to hospital B. So that firstly includes which patient population are we talking about. So if we look at diabetes, is it type 1, is it type 2, or both? Our sets are relevant to both. If you are thinking about treatment types, which treatments are in scope for this data collection and comparison. For our diabetes set, it's all treatments. Most of our sets in general are treatment agnostic, meaning that the disease is really what we're capturing outcomes for, rather than whether it's treated by surgery or this type of medicine. The last standardization is the time points. So you can imagine that, let's say, for an example, for hip and knee replacement, arthritis set or a patient who's had hip and knee replacement, if you were to compare and you wanted to find out, is this hospital A providing better care than hospital B? If patients in hospital A, you're recording pain at day 2 days after surgery, and in hospital B, you're comparing, you're looking at pain 6 months after surgery. You cannot meaningfully compare and draw conclusions from that comparison and say hospital B is better. So it's very important to specify the time points of data collection, which is included in the sets as well. I want to just highlight that patient involvement and amplification of patients' voices is key and part and parcel of this process. We develop our sets with an international working group of experts, including patients, and they are active voting members of these sets. We also have a draft of the set sent out to communities around the patient communities around the world for them to be able to say whether what's been proposed in the outcomes actually rings true to what they find important in their experience, lived experience. And then, of course, including patient-reported outcome measures is important to getting data that comes directly unfiltered from patients on how they are doing. This is an example of a patient validation survey that's sent out. It lists the outcome domains or outcome concepts such as quality of life, functional limitations, and pain. And we ask the respondents to rate how important this is to their disease and living with their disease and its treatment, with 1 being not important and 9 being most important. We then tally these numbers and the domains, the outcomes that are ranking the highest, meaning the ones that are rated 7 to 9, so most important, more than 70% of the time, are included in our set, but the rest are not. And so this is a way to be able to prioritize and not gather all of the outcomes that would be ideal, but really come up with a more pragmatic list of outcomes. And ICHOM works with patient and patient organizations in various ways, in addition to the working groups. I'm just highlighting here at our conference that's coming up in Barcelona in October, we have a session where we'll be hearing from different patient organizations, including IAPO and the European Patient Forum, as well as Movember, who we've worked with for quite a long time now. And just to flag that, in addition to the conference, there are some collaborations that are ongoing. So, for example, the International Alliance for Patient Organization, IAPO, and us are working on a patient charter, which is really a declaration or a manifesto of how collectively we will continue as ICHOM and with IAPO to be able to really actively engage patient participation in all areas of our work. So with the sets that are available, what you have is tools to help you take the sets and use them in your care, in your setting. And that could be a clinical care setting, a clinic, hospital, or it could be in research. It could be in government and policy-related work. These sets are available to download from our website, where you'll get what we call the implementation guide. So it is a listing of the components, definitions that are data dictionary level detail of what the measurement is. You can also download the electronic content of the sets in the form of CSV or JSON file. Over time, we'll have file profiles of each of the diseases as well, all to ease electronic capture rather than paper-based and reduce the burden of data collection. We have trainings, online trainings that are available, and I just want to point out as well that there is an online community that you could log on to for free to ask questions. Again, there was a question about who's implementing in Switzerland. So understanding if you want to reach out and to people who are at a similar phase of implementation, that is a forum that you can use. Our sets have been implemented, have been developed with working group members from around the world, over 1,000 global community now, many of them coming from leading academic institutions around the world. And you can see this geographic representation of all continents. And they've been implemented in over 400 care settings. And I have to say that Europe has predominated in terms of that implementation, and these are some of the numbers. An example I'll highlight of implementation, I think I touched on this earlier, is Martini Clinic, which is a specialty prostate cancer center in Germany. and they started collecting clinical outcomes like survival and disease and clinical endpoints, as well as patient-reported outcomes such as 1 year urinary incontinence and severe erectile dysfunction. And what you see from the slide, I like it for two reasons. One is it's a comparison of Martini Clinic, which is in blue, which is in blue on the right, as well as, and it's being compared to national averages of Sweden and Germany. And when you look at 5-year survival, you see that this is pretty much good across all areas. But when you look at the patient-reported outcomes, you see that Martini Clinic outperforms the other comparators. And this is important to see because when patients survive prostate cancer, that's wonderful. But if they survive and they have urinary incontinence or severe erectile dysfunction, that significantly affects their quality of life. The other thing to note is that you can see the variation in these outcomes. So it's opportunity to look at what's Martini Clinic doing differently that can be learned and shared in other care settings in Germany, but also in other countries that can really help accelerate the learning and gleaning of best practices. So as a result of its work and its excellent work and learning environment, Martini Clinic has really led value-based healthcare and in clinical excellence in prostate cancer, and they have influenced practice at other centers, including the certification through the German Cancer Society of measuring patient outcomes, and also been endorsed by Movember, which is an international patient organization. This is my second to last slide, I believe, and this is really to round out the point around how to gain value, what can be gained from measuring outcomes that matter to patients. I think all too often, the interpretation of putting patients first in measuring outcomes can tend to mean putting patients only as those who stand to gain from measuring this way. But actually, if you measure outcomes framed in this way, they can be beneficial to all stakeholders. And I think I've touched on some of those examples. Patients will be able to engage more actively in communication with their clinician. They may, for relevant conditions, be able to manage themselves better for conditions where prevention and self-care are important. Clinicians will be able to improve rapport and quality of care, learning from the experience of others in others' care contexts. And in terms of payments, the insurers and governments can find more evidence to be able to say we will pay for what good quality looks like, but quality being defined with a caveat, quality being outcomes focused more than process focused, and also looking at outcomes holistically, including from the patient's perspective. This is just to say that, value-based healthcare the concept of it has been around for many, many, many years. There is impetus and acceleration of and interest in making it happen. I do recognize the need, as mentioned before, of needing to walk before you run. But it really does feel like there's a wonderful moment and a window of opportunity at the moment in the context of COVID. I think the COVID pandemic has really highlighted big cracks in the health system and the need and the demand for including patient perspective and patient voice much more. And we see that a little bit with some regulations that are on the horizon here and also internationally. I think also it really is key to helping with moral injury or the purpose crisis, where clinicians are burnt out and they're leaving the health workforce because they feel that they're not doing and serving the purpose that they came into the profession for. And so it's an opportunity to really be able to address this crisis that is being faced around the world. That being said, I wanted to highlight two things. One is, as we are accelerating with scaling value-based healthcare, it's important to make sure that the patient voice and patient perspective and patient outcomes involves all patients. So by all patients, that means patients with disabilities, right, who or patients who might be marginalized otherwise, such as disabilities, or patients who have low digital literacy for various reasons. Patients who are of race and ethnicities and educational backgrounds that, again, limit them in terms of being able to access high quality care. And of course, the discussions around using data to glean insights and predict needs to be done in a way that doesn't bias the results. So it's important for us to be thinking about all of this as we move forward together in scaling and implementing value-based care. So in conclusion, I hope I've been able to share with you simply that patients care about quantity as well as quality of life, that ICHOM sets are internationally endorsed tools of measuring outcomes that matter to patients in a way that is scientifically sound, is inclusive of patient voice, and also is standardized in a way that you can really be used for analysis that is meaningful and credible. And finally, that all stakeholders in society stand to gain from putting patients first. Thank you.